Hello everybody, my name's Barry James, and as Sam has just told you, I'm the Palliative Care Funding Programme Manager for NHS England. And what I'm going to try and do very, very quickly is cover a very broad and very big topic, which is the current climate and future opportunities and challenges as seen from the perspective of NHS England. So, what do we know? We know that people are living longer, but not always well. We know that the larger the number of comorbidities a person has, the lower their quality of life generally is. We also have evidence that early intervention of specialist palliative care increases the quality of life of patients. There are approximately 470,000 people who die each year in England. This number is expected to rise by 20% by 2035. And 3/4 of these deaths are expected. In England and Wales, 84% of deaths in 2013 were of people aged 65 or older, and 39% were of people over the age of 85. At this moment, 25% of all hospital beds are occupied by someone who is dying. The National Audit Office estimates that at least 40% of these people have no medical need to be there. Good community-based end-of-life care could reduce hospital costs by £180 million per year. Hospice UK has indicated that the independent sector contributes £1 billion annually to the provision of specialist palliative care. The government's mandate to the NHS states that by 2020 we will significantly improve patient choice at end of life, including ensuring an increase in the number of people able to die in the place of their choice, including at their home. There's a huge body of work going on out there to improve services at local and national level. This slide shows just a few of the reports and recommendations that work is generating, and you've heard others as well this morning. The sector's changing, reducing unwarranted variation through quality standards and service specifications, touching more lives through community-based engagement, and moving increasingly into non-cancer conditions. Every organisation is playing its part in raising awareness of the issues and suggesting ways forward. From the large national organisations to the small independent hospitals that have tested the currency or helped inform our thinking, I'd like to say a big thank you, because I know that you all do it voluntarily and it takes up a huge amount of your time, and it's been very enlightening from my perspective. We've come a long way in the last 4 years, so let's have a look at what the future holds. We started the journey with a government white paper in 2010 and the Palliative Care Funding Review in 2011. In July this year, we published Palliative Care Currencies in the tariff engagement document on page 66, in case you haven't seen it. We're currently finalising guidance documents to support the use of the currencies, and these should be ready for publication in December, in case you're wondering. You know, it's just a list of codes and makes no sense. Publication in NHS England, some of you may be aware, is a very lengthy and time-consuming process. So the documents are already ready, and they're out with our advisory group and our executive steering group for their comments before we go into the final publishing run. You might be forgiven for thinking it took an awfully long time to get here. Well, it took the Australians, who were the first, 13 years to publish their first currencies. We've done it, thanks in part to their work, in 4 years. But I should stress, this is not a tariff. There are no prices associated with the currency units. And we're no longer wedded to the notion of a per-patient pricing system. The currencies are building blocks that will support a variety of payment mechanisms. You should view them as a way to demonstrate the complexity of patients being cared for and the increasing complexity of the care that you provide. Experience from the pilot sites has shown it takes approximately 12 to 18 months to fully embed the language of phase of illness and IPOS into clinical assessment and management processes. So for those naive to the currency, you'll find its language intrinsic to the work of projects such as OAK and its outcome indicators and the clinical data set. You have a journey ahead of you. There are others in the room better qualified to speak on such things and already have, so I'm going to leave it to them to cover that. But here are the currencies. Currency units are split into adults and into children and young people. There are 28 units in each group, spread across 3 settings: acute hospital, hospice, and community. We mean something slightly different about community than you tend to read into it. Acute hospital reflects the costs associated with the advisory role of palliative medicine within acute hospitals and is a top-up covering the cost of palliative medicine interventions at the request of admitting specialties. Community is a catch-all, and in this instance it means all non-bed-based services where the patient either travels from their normal place of residence or receives care at home. The units are based on the best predictors of cost. Those that were engaged in the pilots and last year's testing will tell you they were not the only items of data we collected. We looked at a wide range of possible predictors of cost, collecting 139 data items per phase of illness, giving us a very, very rich data source of over 2.4 million data items. I've already mentioned in previous presentations phase of illness, so I'm not going to dwell on this slide for very long, but I just wanted to show you what some of our data illustrates. And I should stress, for the uninitiated, that phase of illness doesn't just look at the patient, but it looks at the patient and their environment. So it includes carers and family circumstances. A patient may be clinically stable, but because their environment, through perhaps carer distress, has become unstable, their condition and their phase of illness is then unstable. This slide represents test data from 2015 testing. It could be that it's just sample bias, or it could be that we have here a demonstration of increasing sophistication of services in the community sector. The original pilot showed that the vast majority of community services were provided for stable phases. And here you'll see that they're pretty much even across all phases of illness. I'm hoping that the sample shows that community services is becoming increasingly sophisticated and increasingly important. But then that's my bias, because I'm also now responsible for community services currencies as well. During the course of the last 4 years, we've had quite a lot of interesting feedback. A lot of it quite unexpected consequences, mostly good, and that's what I'm reporting here. And of course, you've already heard St Luke's talk about their MDT meetings and how it's allowed them to condense their sessions. But I think when they started the process, and Judy can correct me if I'm wrong, but I don't think that they actually expected it to be as successful as it was. North London Hospice had such a good response from their commissioner by using the data collection template that they have continued to use that template even though data collection process is now over. And small independent hospices have found, such as Blythe Hospice in Glossop has found that they're in a better position to explain to their commissioners the impact that they're having on the local health economy. And I should say that IPOS is very much a part of the currency and the currency units. So all the things that have been talked about are there within the currency. Ultimately, we'll be looking to refine them as we go. The tariff for this year is a 2-year tariff, so we are not expecting to make any significant changes to the currency for at least the next 2 years. That means that we've got 2 years to collect more data and to refine the process. It means that we won't stop, but we'll continue to review. The currencies are there for voluntary use. They've not been mandated, and they wouldn't be mandated at this stage, but we hope that they will be used. Sarah is going to be speaking after lunch about palliative care clinical data set that was funded by NHS England and led by Public Health England. And Sarah, of course, was the chair of the Clinical Expert Reference Group. What I do want to say, though, is that although this project has not been funded further this year, I'm currently charged with developing data content for phase 2 of the soon-to-be nationally mandated community services data set. And we're looking at how we might include much of the work that was developed in the palliative care clinical data set into that structure, which will then be a nationally mandated data set. We'll probably change a little bit the structure, because one of the things that NHS Digital are trying to do is they're trying to convert most values into SNOMED. So an early step would be to get acceptance from the UK registry for IPOS to become SNOMEDized, if I can use that term. Phase 1 of the community services data set should start to flow data by the end of next year. The expansion I'm talking about will run on from there, so we're probably looking at 2018-19 before we start to collect that data on a national basis. And then just quickly, what else is going on? Well, there's quite a few things going on. Just to mention a few of them, there's the 24/7 specialist palliative care model evaluation. There are clinical advice hubs as part of the urgent and emergency care programs. And we're looking at community nursing 24/7 teams, just to name but a few of them. The overriding feature of the 5-year forward view is how do we pay for health services? With a projected £30 billion per year budget shortfall by 2021, significant efficiency savings have to be made from cost avoidance and cost reduction. But even if all those efficiencies are met, there will still be a need for at least £8 billion per year more from the government. NHS England is investing in new ways of delivering care, looking at removing system blockages and incentivising integrated ways of working. The map actually shows you the many vanguards currently engaged in new models of care, so MCPs, multi-specialty care providers. Right care, integrated care teams within the community. PACS, primary and acute care systems. And now, of course, we've got ACCs, the acute care collaborations, on top of sustainability and transparency plans that are set to change commissioning landscape yet again. You may think the whole population budgets that these are going to be based on are a return to the old block contract. But these budgets will be supported by clear values based on currencies and contracts with embedded outcomes for both efficiency and effectiveness. There's no future soft options in the way the health service is funded. NHS England is being increasingly less prescriptive about the process of care delivery, but much more focused on the effectiveness of the care that is delivered. And so it's quite appropriate that we're really talking about outcome measures today. So we're looking for the right care at the right time for the best possible outcome for the patient, improving the quality of people's lives and the health of the population as a whole. My question and challenge to all of you, and I have to say I don't have an answer. I don't believe there is a single answer, but my question is, well actually my questions are, how can you bring specialist palliative care and end-of-life care back into mainstream delivery? How can your organisations touch more lives? How can you engage in and support a sustainable future for yourselves as independent organisations and be an active participant in the ethos of integration and new models of care, which is the reality that we find ourselves in? And actually that's a very, very short, very rapid presentation. But thank you for listening to me. And if you do have any questions, I'm quite happy to answer them now. But if you don't want to ask them here, you can always send them to me through the england.pcf@nhs.net email address, or directly to me, barryjames@nhs.net.
One of the things that I've been aware of over time, Barry, is the difference in the currency units for different kinds of clinical settings. And I suppose in terms of some of the things we've talked about this morning and about growing different individual systems, and we know NHS England doesn't really prescribe things anymore. In terms of the maturity of the sector, from your perspective, how important is it for us to engage in kind of discussing and developing ways to tackle these currency items as a means of giving our sector a sustainable future?
Well, I'm quite biased, so I think it's incredibly important. But I think that we've already had a presentation from St Christopher's about how they want to use outcomes and they want to use and redevelop currencies. A lot of the ways in which you're paid, I believe, disincentivize financially your organisations. The currency is a way to look at how you might re-incentivise. We've been looking at various payment mechanisms that might be supported by the currency, and one in particular was developed for urgent and emergency care, and it's called a three-part payment model. And those three parts are an initial core payment that recognises there are costs associated with any organisation in order for it just to exist. Then there is an element which is the volumetric payment that deals with the numbers of patients that you see and the complexity of the care that you provide. And the third element, which is a more difficult one to work out and negotiate, but the third element is, in some respects, a replacement of sequins. It's how you incentivise the development of the service, how you incentivise the growing maturity of standardisation and its application, the work that you will do with other organisations. You already do an awful lot of work with other organisations. You are already experts in integration, but it's not visible and it's not recognised. Instead of being paid 1 or 2% for sequins, that incentivisation could be as much as 10%. It depends on how it would be negotiated with your commissioners. But I think there seems to be a groundswell. When we started this process, we were in that field of 100 blooms, I think that we're becoming a lot more consolidated in the way that we approach palliative care. We have an emerging language that allows us to describe the care that's given. Using that and the evidence that that generates allows us to make comparisons on local and national levels. And I think that is important for bringing palliative care back into the mainstream. That is my personal view. I think it's probably shared by some of my colleagues in NHS England, but I obviously am here supporting this discussion on outcomes because we strongly believe there is mileage from that. We can grow this sector into the position that it should be in.
Thank you very much, Barry.